Hi there, my name is Paul Bryan. I'm a second year family medicine resident. I'm going to do a short presentation on palliative care emergencies. Apologies for my voice, I'm just getting over an illness, so please bear with me. So, first, just to start with, palliative care emergencies might seem like a bit of an antonym, but uh, really, emergencies just means that there's a time sensitive nature and there's prompt need for evaluation, investigation, and management of these clinical situations. And palliative care patients who have, end organ disease and or high burden of cancer, they're at high risk of clinical situations such as these. And they actually, you run into situations quite often where you need to, as I said, promptly assess the patient, investigate, and manage them in order to get a better outcome for the patient. So quickly just jumping into what can happen, what we'll talk about today. So spinal compression is a common thing that's talked about in clinical situation you should be aware of for palliative patients. We're going to talk about hemorrhage, convulsions, fractures, and acute confusion or delirium. There's many other things such as, a pain crisis or superior vena cava syndrome, hypercalcemia if it's severe enough, as well as just other, non-specific medical emergencies that can happen to these patients. But these are the ones we're going to focus on today. In terms of an approach overall to palliative emergency, you have to consider a few different factors, including what's the goals of care of that patient, what's their functional status currently, and what are we hoping to reverse, and is it actually reversible? So just to simplify that a little bit, what would a success look like for that patient specifically, and then is a successful management possible based on the patient factors and the etiology that we're seeing? Really the most important thing is to anticipate. So here I just had a couple general approaches and strategies you can use to try and anticipate these emergencies happening. So what specifically are they at risk for based on their disease and their terminal illness and previous medical history. Have they been exposed or been at risk of these emergencies before and actually had them present? And then, I think it's really important in terms of anticipation to make everyone aware of what can happen, what things will look like, and what we can do about it. And that can help align with the patient's goals and make everyone comfortable with it. And then putting that into a plan, and making sure that everyone's agreeable to all the aspects of that plan. So, first, we'll just jump into spinal compression. So, just for a general overview, basically, spinal compression is due to the vertebral body cancer metastases having mass effect on the spinal cord, and it varies by severity, but basically there's an equally likelihood that the metastases happens anywhere in the spinal cord. So just based on the volume of each vertebral body area, that's the distribution we see. So 10% in the cervical spine, 60 to 70% in the thoracic, and 30% in the lumbar. But remember, it can happen anywhere. And again, there's certain cancer types that have a propensity for metastasizing to the bone and potentially presenting with spinal compression, which is quite common in all terminal cancer patients. About 3 to 5% of them will clinically present to some degree with spinal compression. And it can be present at diagnosis in a good chunk of cancer initial presentations as well. The most important thing to remember is that we can grade how severe this is mostly on imaging. So high grade is anything that shows actual compression of the spinal cord. Anything even up into touching the spinal cord is still considered low grade, at least on imaging. So here's all the different factors of the presentation, how we investigate and how we manage it. And I won't go through all of it in detail, but most importantly, we'll talk about the presentation. So typically the two main things is pain and neurological deficits. So with pain, it's typically slowly progressive, and the classic characteristics of this pain is to be worse at night and also potentially worse with Valsalva maneuvers, and that's mainly due to the decreased endogenous corticosteroids that happen at night, and hence why we would treat it medically with corticosteroids and see improvement in pain. Valsalva maneuvers is basically due to the increased pressure and edema that we think is causing the actual damage to the spinal cord. So that compression causes vasogenic edema, which progresses to potential infarction of the spinal cord and permanent neurological damage. So the motor deficits that we see, the main ones is it depends where it is in the spine, but below that level we'll see deficits. And if it's in the thoracic spine, typically you see quite severe motor deficits and weakness. as opposed to in the lumbar spine, you can get things like cauda equina syndrome and typically more so asymmetrical weakness. When things get advanced neurologically, that's when you start getting bowel and bladder incontinence. And then the other feature is the ascending numbness as a sensory deficit. So any patient who has a known cancer diagnosis or has these symptoms suspicious should be investigated with an MRI. The entire spine should be imaged. Commonly, there's not just the clinically significant lesion, but many other lesions that then can be addressed in management. It's important to keep a wide differential with these patients. There's many other potential causes, but if you're suspicious of spinal compression, you should get the imaging, and then you can assess based on these 4 parameters. So it's the NOMS, mnemonic, so neurological, again, mainly graded based on imaging, high grade versus low grade. High grade has that spinal compression. Oncologic, so what's the cancer phenotype and how does it respond to our potential therapies? And then the really big thing is mechanical instability, and there's a score to assess for that. It has pretty good sensitivity and specificity listed there. The other thing to keep in mind is if movement is something that causes the pain or greatly exacerbates the pain, you're definitely more suspicious for an unstable spine. So you'd want to be very cautious and seek, urgent surgical consultation for that patient. Really, the goals of therapy is pain control and to preserve neurological function. We do that medically with corticosteroids, but we do need definitive therapy typically. You also usually need opioids for pain control, so keep that in mind. Corticosteroids usually alone don't suffice. And the definitive treatment is radiation plus or minus surgery. So radiation, is particularly effective in certain cancer types. And then, the ones that aren't as reliant on us, we do need to rely on surgery for that. So the main surgical indications would be an unstable spine, so a high score in that SIN score, which scores spinal instability, or, that feature on physical exam of movement exacerbated pain being a prominent feature. And then also if it's a high grade lesion on imaging and has compression of the spinal cord, and it's a radio-resistant cancer where we may not see quite as quick effect with radiation on the tumor, then we do typically need debulking surgery. So those would be the 2 main indications for surgery. Of course, all of this has to be kept in mind with also the systemic burden, which is the S of the assessment, and what the prognosis and goals of care of this patient is. Typically, prognosis is worse the longer that symptoms are going on and the more severe that they are. So again, late symptoms is bowel and bladder incontinence, as well as, severe weakness. Median survival is quite short with presentation of this condition, and that can be split again. They're dichotomized into ambulatory, which have a longer median survival of 8 to 10 months, and then non-ambulatory or more neurologically impaired patients at presentation have a much shorter median survival of 2 to 4 months. And your chance of retaining ambulation is fully dependent on the severity of your presentation as well. Moving on to catastrophic hemorrhage. So this is something that patients are at risk for because of tumors in certain sites that have non-compressible bleeding areas, and then also they have potentially medications such as DVT prophylaxis, antiplatelet agents, maybe underlying liver disease that could all predispose them to having a catastrophic bleed that ends their life quite quickly. Things and sites where we see this would be gastrointestinal bleeds, pulmonary bleeds, intra-abdominal bleeds, and intracranial hemorrhage. And all things that they have in common is that they're not being able to be compressed easily or stopped easily and easily reversed. So if it's an irreversible and fatal bleed, then palliative emergency sedation is warranted. And typically what I've seen done is using midazolam, so quite high doses of 5 to 10 milligrams, and you can give it subcutaneously. You can give it quite quickly, and mainly the goal is to give enough sedation to cause the patient to relieve all suffering, and that's something that can be communicated easily through like RAS scoring, but the general principle is the least amount required for adequate relief of suffering. Obviously, in this situation where it's potentially a fatal and catastrophic bleed, you would aim more so on the heavier sedation, so maybe you would have a RAS goal of 4 or less, but completely depends on how distressed the patient is. It's important to keep in mind that when you're using midazolam, it has a very quick onset of action, but the half-life is only 3 hours, so you may need to do an infusion, which you can do subcutaneously. The other bonuses is it's an anticonvulsant, anxiolytic, and there's a reversal agent. So say we run into a situation where we over-sedate the patient, then we can potentially reverse that quickly with lomazanil. And then the other risks of this medication is potentially paradoxical agitation. It can accumulate if it's used for longer periods, and then you can also develop tolerance to it and have less sedation effect with it. That happens within days. So sometimes an adjuvant needs to be used if midazolam and palliative sedation continues for extended periods of time. And Nazanan, the first generation antipsychotic, is commonly used, and I have some of its features listed there as well, but that would be a reasonable adjunct if you run into, say, paradoxical agitation or tolerance, or you just need greater sedation for the patient. Next, anticonvulsants during palliation. So this is a common issue mainly because of brain metastases. So patients who have brain tumors will commonly have seizures in the last month of life, 30 to 50% of them. And then also previous seizures means that they're showing the propensity to have another seizure in the future. Don't forget about other potential causes like a bleed or stroke that a patient may have, or metabolic derangements that may or may not be easily reversible and can help control of seizures. For management, there is limited options in non-oral routes, so it's important to have a couple contingency plans for if oral route isn't available. Just a reminder that for primary prophylaxis, so someone, even if they're at risk for a seizure, but they've never had one before, that no therapy is indicated. For abortive therapy, you can use lorazepam or diazepam, which is quite typically used, and it's good because we can give these subcutaneously, sublingually, or rectally as well, and you can repeat that regularly for effect. For secondary prophylaxis, really continue the PO meds as long as possible, but you have to be aware of different drug interactions that they have, with the liver enzyme inducing medications, and those are the two big categories of anticonvulsants orally. And if you do lose the oral one, then in a pinch you can use a lot of the actual orally used anticonvulsants in a rectal form. I wouldn't continue doing that long term, but in a pinch when you need to do that and you're worried about seizure control, you could do that. Really the mainstays would be subcutaneous phenobarbital when you lose the oral route, and then also using subcutaneous regular benzodiazepines is another reasonable option. And then you just remember that there is a couple other administration modes with benzodiazepines that you can use if needed. Next, I'll move to pathological fractures. So again, this is common in patients who have cancer types that commonly metastasize to bone, and really the greater the burden of tumors that we see in the bones, as well as the type of tumor, depends on the likelihood of someone having a pathological fracture. So lytic lesions like in multiple myeloma or even in renal cancer are much more likely to cause loss of structural integrity in the bone as opposed to osteoblastic lesions like, for example, with breast cancer. But definitely still possible. And then, obviously exposure to trauma like falls risks would increase the chance of having a pathological fracture. Now, osteoporosis is different, or an insufficiency or an osteoporotic fracture is different than pathological fracture in the sense that a pathological fracture will be unlikely to heal. That's just because of the abnormal cancer tissue that's there in the bone, impairing the healing, while as an osteoporotic fracture may not need to be intervened with as aggressively with fixation because it may potentially heal, but all pathological fractures, sort of as a rule, will not heal naturally and will most likely need fixation. It's quite common, so in patients who have bone metastases, 9 to 29% will have a pathological fracture, and it may actually be their first presentation, particularly that's prevalent in renal and lung cancer. So typically pathological fractures will present with pain, and there's a typical progression in pain. So once a bony metastasis is present in a bone, patients will typically have a diurnal pain where the pain is worse at night. And again, that's most likely due to the variation in endogenous corticosteroids. Now, as pain progresses and there's an impending pathological fracture, pain will become constant and then also exacerbated by things like weight bearing, positions, and certain movements. So having those features clinically would make you more suspicious of an impending pathological fracture, which may need intervention even before you see a clinically or radiologically evident fracture. You also can notice deformity, of course, most common in the long bone fractures. And also consider if a patient becomes suddenly non-ambulant, they have a lower extremity pathological fracture and should be assessed for such. Complications of pathological fractures include spinal cord compression, which can happen acutely or due to mass effect from a tumor. Hypercalcemia happens in these patients as they do have bony metastases. Also, the loss of function and mobility in and of itself, but also leading to venous thromboembolism. And typically, these patients do need operation in terms of definitive management, and that operation or fixation can fail and reoperation can happen, but less than 10%. Really, the main goal in management is to improve pain and function and to choose something that will outlast the patient's expected survival and be in line with their goals. So, for analgesia, typically it requires opioids. And then also bisphosphonates or denosumab, which are osteoclast inhibiting agents, will usually be indicated. These increase future fracture risk, decrease bony metastasis pain, and increase quality of life. These are reproducible results in multiple trials, but they're all quite modest, and they don't actually treat a pathological or impending pathological fracture that's already happened or is occurring. It's important to keep in mind that when you're thinking about a pathological fracture as well, there is scoring systems to try and find the risk of an impending fracture and see if that a prophylactic surgery is indicated. So one of those scoring systems is Morrell scoring, and another one that we talked about previously was the SIN scoring, which was spinal instability specific to spinal metastases. So again, an indication for surgery would be an impending pathological fracture or an overt fracture that's seen clinically or radiologically. When you do start the bisphosphonates or denosumab, remember to give calcium and vitamin D to reduce the risk of hypocalcemia. Now, the definitive treatment for pathological fractures and impending ones is typically surgical fixation or reconstruction, depending on the site. And typically, after that, patients will also get radiotherapy as this reduces pain, promotes bone healing, decreases the risk of operation due to fixation or reconstruction failure, and improves the patient's functional status. So moving on into acute confusion. So the most important thing is identifying what happens in delirium or acute confusion. So really it's about identifying it, and I use the CAM criteria scoring, which you need both of the primary features, which is an acute fluctuating change in mental status, which again comes in two flavors. So that's decreased activity and basically somnolence, which is the hypoactive delirium, versus the hyperactive delirium where people are restless and agitated. So they need both of the major criteria of acute fluctuating change in mental status and inattention, and then one of the minor criteria, which includes disorganized thinking or includes alterations in level of consciousness. So it's important to identify these things. Now, in terms of differential diagnosis, the thing that's really complicated in a palliative patient is that we have our regular broad differential of drugs, infections, metabolic causes, structural causes, plus there could potentially just be a progression of their natural terminal illness and be a terminal delirium. The thing to do is to thoroughly review the profile and risks, do a thorough history and physical exam, usually relying on a collateral history in patients that are unable to give give appropriate responses to questions. And you want to create a differential of what is this patient most likely contributing to their delirium. Remember that there could be multiple contributions as well. The next step is to work through that differential diagnosis. And again, this is the most difficult thing, is you have to put everything in the context of the patient and try to judge, what is reversible and what would be the main benefit and goal of treatment for this patient. So you have to consider what's the pretest probability based on your assessment, how will they tolerate the investigations and the therapy, what's the chance of that therapy being effective, and how does this all align with the patient's goals and current functional status and prognosis. For example, things can vary widely in terms of what you're suspecting, in terms of what you should actually pursue for investigations and treatment. So, for example, if the patient becomes delirious and has a fever, if they have features of a UTI, that might be reasonable to investigate and treat with an antibiotic, versus if someone has a meningitis, then we're unlikely depending on their functional status and goals of care, to warrant, a lumbar puncture for investigation that's very invasive, and again, IV antibiotics that would likely be needed. Other examples of this would be, let's say, a patient um, has uh, um, hypovolemia on exam, and they could be just simply hypovolemic, and we can rehydrate them, and it's a hyponatremia secondary to that hypovolemia that's causing their delirium, or it could be a massive GI bleed that we just haven't seen the blood yet from. And obviously, those would have very different management strategies in terms of potentially curative intention versus just palliative sedation or further palliation. Um, uh, if a patient has dyspnea, it could be something as simple as a pneumonia, which can be investigated non-invasively with a chest x-ray and then treated again with oral antibiotics, versus an ARDS where patients might require quite invasive interventions such as intubation even, and intensive care, which obviously isn't in line with many palliative patients' goals, but this all has to be thought about in the context of the patient. Um, in terms of management, really the most important thing is try to identify the underlying cause, and don't forget about those conservative interventions as well. The real goal of treatment is trying to make the patient comfortable and make the the care environment safe for the care providers and for the patient as well. Just remember that sensory deficits such as pain, um, not using corrective lenses, inability to hear can all contribute. So doing the regular comfort rounds things is always important. Now, especially in a terminal situation like a terminal delirium, or if it's just not in keeping with the patient's goals of care, then sometimes we're not able to address the underlying cause directly, and sometimes these conservative interventions aren't enough. So when that fails, then we are left with other things that we may need to consider, like haloperidol is a medication that commonly is used, particularly in hyperactive delirium, and there's a round-the-clock dosing that can be used. And again, these can be titrated to a certain RAS, so a RAS less than 1 would be appropriate, because again, if you go back to the RAS scoring system, that would be someone who's just simply comfortable and not agitated or anxious at all. Alternatives to haloperidol would be other second generation antipsychotics. Just remember that there is risks in using these, and some of these things can actually be counterproductive in what we're trying to do. So the risks in terms of the extrapyramidal symptoms that happen progress along a timeline with antipsychotics. And the first ones that happen are the dystonic reactions, which you may notice and pick up on just by observation. But then the next one that happens as early as 1 week after treatments with antipsychotics is akathisias, which again could mimic or could look like a hyperactive delirium. And so it's important to consider, am I contributing to this patient's discomfort and restlessness due to antipsychotics, or am I actually treating it? And it's a difficult balance to know which way to go, either down titrating or using an alternative medication versus increasing the dose of antipsychotics. But it's important to keep that in mind. And remember, sometimes you do need to use adjunctive medications such as benzodiazepines to help control the symptoms of irritability and agitation, again with the main goal being a patient's comfort and safety. That's the end of my presentation. I have a few references listed here. I used a lot of different up-to-date articles, and then these 2 articles as well that touched on all of these presentations and was very helpful in terms of general approach as well. Thank you for listening, and I hope that you learned something, and I hope that this was helpful.